And if we have time, we are going to start talking about leukemia and some of the blood disorders that have to do with the excessive proliferation of different cells. Okay, yesterday we covered different anemias like iron deficiency anemia, sideroblastic anemia. Okay, I will stop here. We're going to talk about thalassemia or the thalassemias, okay, which are a group of disorders that have a classification that you will learn, in which there is a difficulty. There are mutations or deletions of different genes that code for the alpha or beta globin proteins. Okay. It's interesting to know something. Remember, most of these autosomal chromosomes, okay, we have two pairs, one maternal and the other is paternal, so we have two copies for making different proteins. Okay, randomly, our cells choose taken from one of the chromosomes to make the proteins. If there is any problem with this allele or with this copy, if there is any mutation, they change, and instead of taking the paternal, take from the maternal part. But look at this, for the alpha globin, we have two copies in each of the chromosomes, in the maternal and in the paternal. So in total, we have 4 genes to code for this alpha globin, and we have only 2, okay, to code for the beta globin. Okay, so for the beta globin, we have, like for most of the proteins, 2 copies, and we have 4 copies to make the alpha globin protein. Okay, so we are going to have different classifications depending on how many copies of these genes are deleted or present with mutations. Okay, so we have 4 possibilities in the alpha globin and 2 possibilities for the beta globin gene. Now, depending on what mutations, how many mutations, what type of mutation we have, these people are going to have a different impairment in the synthesis of hemoglobin that go from mild conditions, okay, mild anemia, to moderate anemia that requires some treatment and some transfusions once in a while, or very severe anemia, or in some cases, diseases that are incompatible with life, as we are going to see later. Normally, these people, when they present symptoms, the symptoms start appearing at the month 6 to 9 of life. Okay, the fetus has a special type of hemoglobin that is called hemoglobin F, or fetal hemoglobin. After we are born, this hemoglobin, the levels start decreasing in blood, and the adult hemoglobin, or hemoglobin A, starts increasing in blood. Okay, when this age is reached, the month 6 of life, the levels of adult hemoglobin are higher than the levels of fetal hemoglobin, so the symptoms of thalassemia will start appearing. The classification, well, there are 2 groups of thalassemias, thalassemia alpha and thalassemia beta, depending on which globin genes are, or have the mutations, or have the defects. People who are heterozygous generally are asymptomatic, unless they have any other problem. And the homozygous normally have life-threatening clinical manifestations. Okay, so these manifest as an autosomal recessive condition. If they are homozygous, of course, they are going to have more manifestations. These people are going to have a normal or increased red blood cell count. Okay, they are going to have, remember, the problem is in the globin gene, in the quality of the hemoglobin. It's not in the production of the cells, but in making the protein. Makes more or normal amounts, but defective. They can have splenomegaly, hypochromia, microcytosis, and some findings that you can see, for example, in the blood smear, which are called target cells, and some cells that are called teardrop cells that have the shape of a teardrop, and something that is called basophilic stippling. That is not specific for this condition. It can appear in certain other conditions. So you're going to see several of these things when you go to the lab, and you're going to see many slides of blood smears, and you're going to see some examples of what is anisocytosis, poikilocytosis, teardrop cells, target cells, and this basophilic stippling. What are findings that can appear in these conditions? Let's just to remember what is the hemoglobin. It contains 4 chains, alpha, 2 alpha, and 2 beta, with this porphyrin ring that is called the heme that contains the iron in the center. Okay, so mutations here or mutations here can lead to alpha or beta thalassemia. Well, here we have alpha thalassemia. Okay, notice that we have 10 million heterozygotes worldwide. Okay, so there are 10 million people who are carriers. Remember, this is an autosomal recessive condition. So if they don't marry with another one, part of the offspring will be carriers. If they marry another who is heterozygous, remember, part of the offspring is likely to be homozygous. These individuals are normally from areas in Asia and Africa, tropical areas. Okay? Type of patient, important to remember this data. Okay. Now, this occurs in these areas because these areas are endemic for malaria, and alpha thalassemia, a single alpha thalassemia gene deletion will confer protection against malaria. Okay, Plasmodium falciparum, which is the agent that produces malaria. And we have to know that depending on how many genes are deleted, remember we have 4 genes for the alpha globin, people are going to have different manifestations. Okay? And there you have the description of how these people look like genotypically and how they manifest clinically. For example, if someone has a single gene deletion, there you have the 4 genes, the genotypic description. You have the 4 genes, 2 A's and 2 A's, maternal, for example, and paternal chromosome, 2 copies and 2 copies. Deletion of 1, this person will be a silent carrier. This is part of these 10 million people who are carriers, silent carriers of the disease. Now, if someone has 2 genes deleted, notice that the deletion can be the 2 copies from 1 parent or 2 copies or 1 copy from each parent, okay? Depending on how the inheritance occurs. Now, there are 2 deletions. This is called alpha thalassemia trait. Okay? These people normally are going to be asymptomatic unless they are exposed to severe conditions or to oxidative stress or go to high altitudes, etc. But in normal conditions, they are going to be asymptomatic. Now, some people are going to have a deletion of 3 genes, okay? 2 from 1 parent and 1 from the other. Now, this single gene will have to try to compensate the absence of the other 3. And this is going to be very difficult. This is called hemoglobin age disease. And these people are going to have moderate anemia. Okay, these are going to be symptomatic. Alpha thalassemia trait is going to have mild anemia, okay, and that is going to be exaggerated under severe conditions. Hemoglobin age disease is going to have a more moderate anemia. The last one is called hemoglobin BART, okay, and it's the most severe of the 4. Notice that there is a deletion of the 4 genes. Notice that you have only 2 lines there in the genotypic description. Okay, this disease becomes manifest in the late stages of the fetal development, so intrauterus. Normally, in the past, this was totally incompatible with life. Okay? Remember, during the intrauterine life, there are 2 stages, the embryonic and the fetal. Also, there is a change in the hemoglobin. There is some genes that code for the embryonic hemoglobin. These are working fine, but when there is a change from the embryonic to the fetal hemoglobin is when the disease starts manifesting. The red cells contain what is called hemoglobin BART that normally is totally ineffective to deliver oxygen to the tissues. Okay, causing, of course, anoxia, edema, necrosis of the tissues, hepatosplenomegaly. Normally, these children used to die intrauterus. Nowadays, some people do aggressive intrauterus therapy like transfusions, and some individuals may be saved if we do these treatments. But imagine that you have to give intrauterus transfusions to fetus, etc. What is the cost? What are the risks? What are the benefits of that? So, in many cases, this is totally incompatible with life and is called hydrops fetalis syndrome. Well, the findings, remember, most patients are totally asymptomatic. Okay, most patients have silent conditions or are carriers having simply a mild anemia. If they have anemia, they are going to have the classic symptoms: shortness of breath, fatigue and weakness, paleness, all of these things that is common to all anemias. If they are producing blood cells in other tissues, okay, outside the bone marrow, if they have what is called extramedullary hematopoiesis, they are going to have hepatomegaly, they can have splenomegaly. Okay? Hepatomegaly can be explained not only by the extramedullary hematopoiesis, also because of hepatitis or because of iron overload. Remember, the patients that are symptomatic require blood transfusions. Blood transfusions increase the risk of hepatitis and increase the risk of iron overload. They can have cardiac failure and arrhythmias as a result of iron overload and a result of anemia. Remember what happens with anemia. There is a thinning of the blood. Okay? There is more plasma than red blood cells. So we have this called high cardiac output heart failure. So two things that can explain the heart failure and arrhythmias. Splenomegaly again, because of the hematopoiesis in the spleen. They can have gallstones that are made of bilirubin. They're going to study gallstones can be of different types. Most gallstones are from cholesterol, the ones that exist in most patients. Now, people who have hemolysis, okay, all of this excess bilirubin in the circulation is going to end up in the gallbladder forming bilirubin stones that have a different colors from the cholesterol gallstones. Also, they are going to have malnutrition, okay, weight loss, cachexia. They are going to have muscle wasting because we are trying, the body is trying to make more red blood cells, okay, and this rapid growth of blood cell precursors is going to take lots of nutrients, and the rest of the body is going to suffer the lack of nutrients. Okay, and this is, of course, mostly seen in developing countries. Okay, probably here, you're not going to see people with this malnutrition because here there is more accessibility to resources than in other countries. And also because of these iron overload, people can have all of the findings of hemochromatosis with this bronze skin as a result of the cutaneous iron deposition that enhances the melanin production. Remember, just the iron and the excess melanin will give this bronze skin. But this is the chart or the diagram that shows all of this mechanism with the clinical presentations. Okay, we have a situation in which we have hypercoagulability. The red blood cells are deformed because of these problems with the hemoglobin. Remember, the alpha or the beta chain are going to be altered. Alteration in the structure of the proteins is going to lead to alteration in their shape and in their structure. This will lead to different conditions: hypercoagulability, dysfunction of the platelets, ineffective erythropoiesis, and hemolysis. Okay. The hypercoagulability state will lead to different episodes of thromboembolism. Okay. The ineffective erythropoiesis will lead to anemia. Okay. The ineffective erythropoiesis will lead also to cortical thinning and bone marrow expansion. The bone marrow is trying to expand to be able to produce more cells. Cortical thinning in the bone means more predisposition to fractures. Extramedullary erythropoiesis that will lead to splenomegaly, hepatomegaly, and this cortical thinning, remember, will lead to more bone fractures. Hemolysis will lead to gallstones that are made of bilirubin. Excess of iron deposition in the visceral organs will lead to different manifestations in different organs, like endocrine organs. if the iron is overloading the parathyroid and the thyroid and the pituitary and the pancreas, testes, and ovaries, will lead to endocrine dysfunctions of different types. Also, the liver can have cirrhosis, and the heart that can have arrhythmias and heart failure. It's more or less the same that we have been telling, but now organized in a diagram. And this is what probably many of us should be doing whenever we study. Okay, you can read a chapter of a book that contains all that information, many paragraphs and paragraphs and paragraphs, and you can simply put it in a flow chart on a diagram like this, trying to connect the dots so you can have an explanation of what is happening in these patients. And then can be answered what is the mechanism of why this occurs, what can happen if, when you see this in these kind of diagrams, you are more likely to understand the pathophysiologic processes than simply reading and reading and reading. Remember, our attention span is very limited. Maybe we concentrate in the first 3 sentences, then we miss the other 2. We focus on the next one, then we miss 3. That's why we have to read the same thing many times, okay? And every time we read, we find something new. I didn't realize this before. Well, this is a picture of a stillborn baby of Hydrops fetalis, okay? 4-gene deletion, remember? Notice size of the liver, size of the spleen, okay? This is the normal thing that happens in these Hydrops fetalis. Well, in alpha thalassemia we had 4 types because of deletion of 1, 2, 3, or 4 genes. Beta thalassemia is a bit different. Remember, we only have 2 genes, okay? 1 in each of the chromosomes. But these genes can have different mutations. More than 100 mutations. Some of them are milder, some of them are more severe. Okay, so people can have mutation in 1 or in 2, and these mutations can be mild, can be moderate severity, or very severe. So we are going to have a wide amount of presentations. Okay, a wide amount of presentations. But we can divide the beta thalassemia into major classes. One is called B0, in which no beta globin is produced, not at all, so this is going to be very severe, or B+, in which there is a diminished quantity of the, not beta, of the beta globin, okay? Beta is my neighbor. Beta globin, diminished amount. Now we divide the beta thalassemia in beta thalassemia major, which is complete or near complete lack of these mutation, of this beta globin. Beta thalassemia intermediate, as the name says, is an intermediate process. And beta thalassemia minor or trait is the same, in which people have a mild anemia with a compensatory overexpression of the normal gene. Now I want to explain something very well, because this is so you don't get confused later. Okay, notice the beta thalassemia major, okay, has a complete or near complete lack of the beta globin. Okay, this is the beta plus and the beta plus, in which there is a diminished quantity of the beta globin. Here we have another combination with diminished plus 0, and here we have a combination of 0 plus 0. In the beta thalassemia intermediate, notice that we have here and here exactly the same that we have here. B+, and B+, B0. So is this here or should this be here? Well, it depends on the type of mutation. Remember, there can be more than 100 mutations. Some of them are mild, some of them are moderate, some of them are severe. If these mutations here are of the severe type, they are going to produce a very little amount of beta globin, so they are classified as major. So this patient here has 2 mutations of the severe type, and this patient here has 2 mutations of the milder type. So these people here have a serious anemia, These people here have a moderate anemia, and these people here have a mild anemia. Okay? Notice that the difference here is the B is alone, has neither a 0 nor a plus. This is the normal beta globin gene that every healthy person has. So they have a mutation of the mild type, or don't produce any at all in this gene, but they overcompensate. The normal gene is overcompensating and producing enough amount of beta globin gene. That's why we have the clinical classification in severe, moderate, or mild. It's called major, intermediate, or minor, which is exactly the same as trait. Now look at the amount of people. Over 100 million people are carriers. Alpha thalassemia, we said 10 million people. Now we have 10 times more. 100 million people are heterozygous carriers of beta thalassemia. Nearly 2/3 in Asia, the rest between Africa, Europe, and Americas. People normally come from tropical areas. These mutations, the carriers, also are protected against Plasmodium. Okay, that normally is a fatal condition. So confers certain advantage to people who live in tropical areas in which malaria is endemic. And here we have the manifestations. We are only representing minor and major. Remember, intermediate is something in between. Okay, it's like an overlap. The minor type, or the trait, is asymptomatic condition. They can present with microcytosis, sometimes elevated indirect bilirubin if there is hemolysis. Some can present with splenomegaly, and the blood smear may reveal something that is called red cell stippling and target cells. Okay, you don't have to look at any blood smear in the clinical practice. You will have to read reports, okay? And there are findings that correlate with certain conditions. Some of them are very specific, some of them are pathognomonic of conditions, but some of them can be present in 2 or 3 or more conditions, so you have to make your differential depending on these findings. And the major, beta thalassemia major, is also called Cooley anemia. These people have a more severe anemia. Okay? They normally don't survive beyond the childhood. They will have important hepatomegaly, splenomegaly, iron overload, bronze skin, combination of pallor and jaundice. And they are going to have some skull deformities, like a chipmunk face, because of extension of the erythroid hyperplasia into the bones of the skull, in the bone marrow of the skull bones. And some multisystemic manifestations. They are going to end up having heart failure, cardiomyopathy, liver fibrosis, failure of the pituitary and the gonads, pathologic fractures. Remember what happens when we have elevated, or the bone marrow is trying to compensate with increased erythroid production. Okay, the bone marrow increases in size, and the cortex of the bone gets thinner, and they can have many different fractures. So these people normally don't live beyond childhood. Very bad condition. Here we have some examples, okay, of what is called, we have a patient here with beta thalassemia trait, okay, many hypochromic and microcytic cells. Okay, some of them are target cells. Remember, the target cell is the one that has like rings, okay, like a target, and have notice that the paleness of the red blood cell is a lot higher than the normal red blood cells. This is the basophilic stippling. This is an example of a teardrop cell, more basophilic stippling here. And here I put a link. This is for you to study or to read at home. This is not an objective of pathophysiology, simply for you to have these available. If you want to know more about these called inclusion bodies in red blood cells, okay, you have here many examples and explanations of what they are. Okay, they tend to be very common in boards, Okay, sometimes, for example, in the case of anemia, it's very difficult to make a question of the type, what is the most likely diagnosis, by telling you that the patient has weakness, fatigue, and pallor, and shortness of breath. So they're gonna give you the blood smear shows this and this and this and this, and you have to decide between the different possibilities. Okay, and one of the things that they use is Howell-Jolly bodies, Haynes bodies, all of these basophilic stippling, all of these things is what they normally use. So not here, but in medicine, you probably are gonna have some of these. For example, people with splenectomy, they tend to have some inclusions. Okay, hemolytic anemia. There you have the images of what are these Howell-Jolly bodies, Haynes bodies, the explanation, what diseases. For example, glucose 6-phosphate dehydrogenase that we are going to cover. Okay, different conditions. And there you have the Haynes bodies, how they look like in the blood smear, how to differentiate them. Pappenheimer bodies, different things. Okay, basophilic stippling, and different things. Okay, but I repeat, not for PAP. Okay, we are not going to use these things that are more clinical, more medicine type. Well, now we have to go to the normocytic, normochromic anemias. They have a normal size and they have a normal amount of hemoglobin. There are some examples. Okay, here we have normal erythrocytes with normal hemoglobin content, but the cells are low in number. There are many diseases. Of course, they don't share the common etiology or mechanism. They are less common than the macrocytic normochromic and the microcytic hypochromic anemias. And we are going to cover aplastic anemia. Aplastic means no growing, in which there is a damage to the bone marrow for different reasons. Post-hemorrhagic, here we have the acute blood loss. Some acquired hemolysis, for example, autoimmune destruction of the erythrocytes. Some hereditary hemolytic anemias, like sickle cell anemia. And we are going to study here the anemia of chronic inflammation that can have multiple causes and different presentations. And when you have, let me stop here for a second, because when you have this type of classifications, okay, you have to think, for example, in the type of questions that can be asked during the exams. Okay, notice that you have a division of the anemias in three groups: macrocytic normochromic, microcytic hypochromic, and normocytic normochromic. That can be described by the size of the erythrocytes, by the number, and by the amount of hemoglobin. The one thing that I always recommend is try to make an exam, try to make the multiple choice questions. For example, you can take one of these conditions. You can take sickle cell disease. And you can look at the signs and symptoms, family history, signs and symptoms of the disease, what type of patient is more likely to have the condition. And you can create a vignette. Say, 20-year-old African-American male that comes to the office having pain everywhere, and mucous membranes are pale, and blah, 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 all of the signs and symptoms. Which of the following findings is most likely in the blood smear of this patient? What you are asking there is if the student knows that this is a normocytic normochromic anemia. And some findings of the blood smear, okay? For example, the size, the MCV, the amount of hemoglobin, different options. One is going to be macrocytic normochromic or hypochromic. One is going to be microcytic hypochromic, and the other is going to be normocytic normochromic. That's the way questions are made. There is no other way of making questions. Okay, so In order to get trained and learn how to answer questions, you have to know how they are made. And if you make them, you're going to learn how to make them. So you're going to start thinking like the persons who make the tests. Okay? And everything is going to be better. Another question that can be asked is, okay, a patient has this type of blood smear. These are the findings in the blood smear. Which of the following is the most likely diagnosis? For example, if you present a blood smear with a microcytic, with a normocytic, normochromic anemia, they're going to place 4 options. 3 are going to have something that is not normocytic, normochromic, and 1 is going to be compatible with that blood smear. Different ways. So if you learn to group things and to categorize and to classify things, and learn of that, of course, doesn't matter how they ask the question, you're going to be able to answer. Because if we simply memorize the slide of the PowerPoint when you're in a test, okay, you have something that you know that is post-hemorrhagic. Individual is bleeding, of course it's post-hemorrhagic, but you don't remember what it was. It was normochromic, normocytic, it was hypochromic, you don't remember, okay? It's trying to create a diagram yourselves, trying to create a chart yourselves that will help to remember better in the moment that you have a test. So we're gonna cover here one of these conditions that is called glucose 6-phosphate dehydrogenase deficiency. Okay. This is a condition that is an X-linked disorder. Some cases have autosomal recessive inheritance, but that is very rare. Most cases is X-linked deficiency, so it's more common in males, of course. Okay. This occurs more common in people from areas where malaria is or was common, like Sub-Saharan Africa, Asia, Mediterranean region, and the Middle East. Okay, most patients are asymptomatic unless they are exposed to different drugs or different foods that tend to produce oxidative stress in the cells and increase them and produce these manifestations. Normally the most common manifestations, or when we discover that these people have this condition, is because they present with a severe and prolonged neonatal jaundice. When babies are born, it is normal that they have a physiologic jaundice for some days. Okay? But if you have a prolonged and severe neonatal jaundice because of the hemolytic anemia in these babies, in association with infection, okay, following the consumption of fava beans or certain drugs that produce oxidative damage, okay, we are going to suspect that these patients have glucose 6-phosphate dehydrogenase deficiency. Notice that more than 400 million are affected. Remember, most of them are asymptomatic. Remember the area of the world from where these patients come. Notice that there is a group of the population, Kurdish youth, in which the prevalence is from 50 to 70% of the population. These are populations in which there is a lot of intermarriage. Okay? They marry their cousins, they marry people from their own ethnic group. In the US, the prevalence is approximately 10% among black males. This is the group where we find more prevalence because of the origin. The prevalence is 10% among black males. So this enzyme, glucose 6-phosphate dehydrogenase, is required to protect cells against oxidative damage. Many cells, most of the cells of the body have different mechanisms that protect against oxidative damage. Now, these mechanisms are located mostly in the mitochondria and in the lysosomes and in other organelles. The red blood cells don't have mitochondria, don't have lysosomes, don't have any mechanism to protect them against oxidation except this enzyme. It's the only mechanism for which the red blood cells rely to protect them from stress. Okay? And they are constantly challenged by oxidants because remember they are dealing with oxygen. and transforming the hemoglobin from oxyhemoglobin to deoxyhemoglobin. That process produces a lot of free radicals of oxygen. And if this enzyme is absent or is diminished in amount, there is nothing that protects the red blood cells against the oxidative damage. Also, the red blood cells are constantly in contact with white blood cells in the blood. Okay? And these white blood cells tend to release, in cases of infections, in cases of any stress of the body, tend to release some chemokines, etc., that can also damage the red blood cells. Okay? If there is a failure to withstand this oxidation, the hemoglobin and the red cell membrane will undergo damage, and this will produce hemolysis, breakdown of the red blood cells. Now, when there is a hemolytic episode, the bone marrow, okay, signals will get the bone marrow telling that there is low amount of red blood cells. Of course, the signal is erythropoietin. The bone marrow will start producing accelerated amounts of red blood cells, younger red cells, that will have higher levels of glucose 6-phosphate dehydrogenase. Okay, and this will limit further red cell lysis. There can be different crises. The red bone marrow responds by sending to the circulation many young red cells. Remember, these are called reticulocytes. These reticulocytes are going to prevent more damage. During the perinatal period, in the neonatal period, okay, the physiologic jaundice, remember, is going to be increased, exaggerated in these patients because of the heme turnover from the red cell lysis and the liver that has impaired ability to conjugate and clear bilirubin. Okay, the liver is immature when we are born. That's why babies have a little jaundice that is called physiologic jaundice. And these people have the added charge of these hemolysis, so they are going to have the more severe jaundice. Then you have drugs. These drugs are not for pathophysiology, are more for pharmacology. And I wanted you to have them. Okay, these are drugs that tend to produce oxidative stress. Notice that the anti-malarial drugs. You have also dapsone, furazolidone, nitrofurantoin, quinolones, sulfonamides. We have glibenclamide for diabetes, and some other drugs here, and some other foods like fava beans, henna, vitamin K, methylene blue. These agents or drugs have a definitive association with this condition, and some others have a possible association. It's not very strongly demonstrated. For example, aspirin. You have aspirin, more common. You have aminosalicylic acid, probenecid, sulfasalazine, doxorubicin. Different conditions, but these are possible associations. The ones that have the asterisk is because they are not available in the USA. Okay? Furazolidone, pamaquine, glibenclamide, these are not available in the USA. Okay, here we have the clinical manifestations. This condition, you have to look for someone that has a family history or comes from an area or from an ethnic group in which this condition is frequent. They can have a history of infection or exposure to any food or drug that causes oxidative stress. And they can have the signs and symptoms of anemia and hemolysis, pallor with jaundice, dark urine, that means that there is an intravascular hemolysis. We're going to study that hemolysis can occur intravascularly in the blood vessels or extravascularly, for example, in the spleen, in the hematopoietic organs. They can have nausea. This nausea and this abdominal discomfort or sometimes abdominal pain that people with anemia can have is as a result of the enlargement of the liver and enlargement of the spleen. And in all patients, for example, you can have cataracts. This is not very common. And splenomegaly because of the chronic extravascular hemolysis. Okay, there you have the two types of hemolysis: intravascular that will produce a dark urine, and extravascular that will produce splenomegaly. And the next thing is aplastic anemia. Okay, aplastic anemia means no production of blood cells of the three types. Okay. By definition, this is a pancytopenia with hypocellular marrow. If you make a bone marrow aspirate or a bone marrow biopsy, no cells are going to be found there. It's like empty, the bone marrow. And no abnormal cells. What that means? And we are not talking about any kind of infiltration by a cancer, or we are not talking about a leukemia or a lymphoma or nothing like that. The cells, if you find them, they are normal. There is simply a failure of hematopoiesis. There can be reduced red blood cells, white blood cells, and platelets. At least two cytopenias have to be present in order to make a diagnosis of aplastic anemia. For example, the hemoglobin less than 10, platelets less than 50, and the absolute neutrophil count less than 1.5. Lymphocytes can remain normal. Remember, some of the lymphocytes can live decades. Okay? We are talking about the process that stops making new cells, but the ones that already exist will remain in normal numbers unless something else comes and destroys them, like for example HIV or any other thing. So you have low neutrophils, low platelets, and low level of hemoglobin. Now the presentation is what will happen as a result of lack of red blood cells, lack of neutrophils, and lack of platelets. So people are going to have bleeding, petechiae, hemorrhage, pallor, weakness as a result of the anemia, mucosal bleeding, epistaxis, gum bleeding, petechiae, bruising, infections of different types as a result of the low number of neutrophils. In the bone marrow, if you make an aspirate or a biopsy, you're going to find hypocellularity without abnormal findings. So no dysplasia, no blasts, no fibrosis, and no other abnormal finding. It's like an empty house with very little cells. What is the prognosis of aplastic anemia? Very bad. Okay, 90% die within 1 year. Okay, even with transfusions and antibiotics. Okay, 50 to 70% cure with bone marrow transplant. $1 million. And hoping that the transplant is successful. Notice that when you make a bone marrow transplant, you simply put cells and you hope they end up in the bone marrow and they end up being sit there and growing and producing a new bone marrow. Okay, so 90% die within 1 year, even with treatment. Okay, let's have a break for 10 minutes. Okay, remember, anemia can occur for two big reasons. Either we produce too little erythrocytes or we lose too many erythrocytes. Okay, when we don't produce, can be for different reasons. One of them is this. For example, a drug or radiation or any insult to the bone marrow has stopped the production of cells of any type. Okay, or simply the bone marrow doesn't have the material to make blood cells. It doesn't have iron, it doesn't have B12, it doesn't have folate. Okay, so there will be a hypoproduction of blood cells. The other part can be there is an increased destruction, hemolysis, or there can be a loss because of bleeding. How we are going to know where is the problem? Is the problem in the bone marrow, is hypoproduction, or is increased destruction? For that we are going to look at the reticulocyte count. Okay, remember reticulocytes are the immature red cells that go to the circulation and stay there for 1 or 2 days until they completely mature. The normal amount of reticulocytes is from 0.5 to 1.5% of the red blood cells. Okay? There are some situations in which you will have an increased number of reticulocytes. Okay? For example, when you are breaking down red blood cells, or when people is bleeding, or when people move to high altitudes, to compensate for that, the bone marrow is gonna send more reticulocytes to the blood. Okay, you can compare that to when a country is losing a war, it has lost all the soldiers. What they do, they start sending children to the war. It's more or less like that. It's trying to compensate, trying to gain something. So you are going to have a lot of reticulocytes in the circulation. You're going to have a very increased amount of reticulocytes. Now, in some situations, when the bone marrow is not working well, you're going to have a decreased number of reticulocytes, aplastic anemia, low B12, low folate, iron deficiency anemia, anemia of chronic disease. The bone marrow doesn't have iron, doesn't have the material, or doesn't have the conditions to make blood cells. So even though there is anemia, and there is a lot of erythropoietin trying to stimulate the bone marrow, there is no way the bone marrow can make it. Now, what is this reticulocyte count good for? Not only to make a diagnosis, also to see how the treatment is working. You have a patient that has, for example, iron deficiency anemia, and the reticulocyte count is in 0.2. It's very low. When you start giving treatment, you expect that the count increases. And you see that the bone marrow is responding to the treatment. So you also monitor and evaluate how the patient is doing by looking at this reticulocyte count. In a nutshell, it tells you if the bone marrow is working or not, and how is the response to the treatment. So here we have aplastic anemia. This is not a very common disease, not a very common condition. Okay, this, for example, about 2 million people per year in North America and Europe. Okay, in all of the developed world. Okay, there is no gender difference. Patients can be affected at any age, but normally there is a biphasic distribution, tends to appear more commonly between the ages 10 to 25, then is not common at all, and then appears after the age of 60. Okay, this is rare, remember, usually it's idiopathic, we don't know why it happens in some people, but in some cases it may result from infiltration to the bone marrow by cancers. It can be a leukemia, can be a cancer anywhere that infiltrates the bone marrow. Some autoimmune conditions, imagine we develop antibodies against the stem cells in the bone marrow, so they are going to stop working. Renal failure, splenic dysfunction, deficiency or a very severe deficiency of folate and B12. I noticed something going on, I don't know what is, in tranquility. I don't know. I see the first time and now some students like talking too much, smiling too much and doing things. I don't know why. Is there something that I don't know?
There's a paper going on.
Oh yeah, we have a paper and we're like,
Okay. No, I just-
it's kind of funny.
But do it
Yeah,
discreetly.
let's do it later.
Huh?
We'll do it later.
Different things, for example, severe deficiency of folate and B12, infections, parvovirus infection, and important radiation to the marrow, drugs, toxins of different types. Or sometimes can be congenital. Okay, some genetic alteration of the stem cells that doesn't allow them to proliferate or differentiate. These are the drugs or the toxins that are most related to aplastic anemia. The most frequent cause is the iatrogenic radiation. Okay, we give radiation to treat cancers, but radiation has secondary effects. One of them is cancer. So we treat one cancer and we develop another, or we develop aplastic anemia. Some drugs like chemotherapy chemotherapeutic drugs can not only, remember, destroy the cancer cells, the normal cells can be destroyed as well. Okay, chloramphenicol, notice that the aplastic anemia that is produced by chloramphenicol is irreversible. Chemotherapy produces a reversible aplastic anemia. That's why this drug is not very frequently used, because it can have very bad or very serious side effects. Treatments with penicillamine, gold salts, NSAIDs, that we use so commonly, can also produce aplastic anemia. Benzene, okay, it's a chemical compound. For those who work in the chemical industry and are exposed to these compounds are at risk, not only of aplastic anemia, also of infertility and different types of cancers. Hepatitis B, C, and D will produce irreversible aplastic anemia. Parvovirus, okay, the parvovirus produces aplastic anemia between 6 to 12 months after the clinical manifestations. And this is explaining very simply the pathogenesis. Okay, you have a stem cell that suffers an insult, can be a virus, can be a toxin, and two things can happen. One is that the stem cell becomes weak and not able to divide and proliferate, so the division stops there, or the mutations in the DNA make them express different antigens that are not recognized as self by the immune system. So in this case, the T cells are gonna destroy these cells that express new and different antigens, and doesn't matter what is the mechanism, marrow aplasia is gonna occur. Okay, so they're gonna have a hypoplastic marrow, almost empty marrow. These people are gonna present with a progressive fatigue and pallor. Remember all of the characteristics of the failure of the three lines of the blood cells, characteristics of anemia, bleeding as a result of the low level of of platelets. Now that we are talking about platelets, there is many people around that have thrombocytopenia, and we are trying to find the cause, We don't find any reason. Could be alcoholism, okay? It's one of the most common causes of thrombocytopenia, idiopathic thrombocytopenia, okay? Sometimes the patient doesn't tell you, no, I drink only on weekends, a glass of wine. They don't tell you how much they drink. You find that idiopathic thrombocytopenia, well, could be. I'm not gonna continue asking, so I suspect. Yeah. Also, neutropenia will produce fever, symptoms of bacterial infection. Okay. In this case, the lymph nodes and the spleen normally are not gonna be enlarged. This is very important because we are gonna study some cancers of the blood, okay, in which people are gonna have exactly these same findings: anemia, thrombocytopenia, neutropenia. Okay, but in this case, it's most likely that the spleen, the lymph nodes are enlarged if they are infiltrated by cancer cells. So it's very important for our differential. If you make a CBC, normally you're going to find at least 2 cytopenias, but you can find pancytopenia. Remember, the lymphocytes are going to remain normal. Okay, so low reticulocyte count. Okay, you're going to find neutropenia, monocytopenia, and low number of red blood cells and platelets. So you do these tests, okay? Again, low reticulocyte that classifies or identifies the anemia as being hypoproductive. Okay, there is no way the bone marrow can make more blood cells. It is sick. If you make a biopsy, you're going to find a hypocellular marrow. Biopsies normally are the most accurate, the definitive diagnosis of these conditions. Okay. If you do a differential, CBC with differential, as we were mentioning before, 2 cytopenias are required. Okay. If someone has macrocytosis, this could be another condition that is important that you know, that is called Fanconi anemia, okay, or sometimes Fanconi hemolytic anemia. That is an interesting condition. I try to summarize here. But the most important thing that we need to know is that has a very high risk of malignancies besides producing anemia, of course. You're going to find people that have several things. For example, strabismus, low set ears. So the ears, instead of being here, are a bit below. They are going to have frequent infections. Deafness can be present or not. Abnormal thumbs or sometimes absent thumb. So they have only 4 fingers. Hypopigmentation, freckles, aplastic anemia. That's why it's called Fanconi aplastic anemia. Short stature. And it's an autosomal recessive disorder that is common in Ashkenazi Jews from East Europe. And it's present in 1 out of 350,000 people. And the treatment is bone marrow transplant. Okay? This is an X-ray of someone that has Fanconi anemia on the left. Okay? Child with Fanconi anemia that shows the absence of the thumb. And on the right, you have the hand of a child with diamond blackfan anemia that we are not going to study. In this case, has 3 phalanges in the thumb instead of 2. Okay? Also produces hemolytic anemia, has certain similarities with Fanconi anemia, but instead of no thumb, has 3 phalanges in the thumbs. Interesting things to know, maybe for brain ball, I don't know. So someone is going to ask you maybe one day, what is diamond blackfan anemia? This is very classic between some people in hospitals, in clinical rotations, and you go to different places, and you are new there, they start asking you, do you know the syndrome of this and that? Do you know how many layers the cornea has? Do you know? And you get like intimidated. But you don't have to. It's normal that you don't know certain things, and probably you will ask them something about EKG that they don't know. This is a bone marrow biopsy. Okay, remember I told you aplastic anemia was like an empty house. There you see the empty house. Okay, this is a normal marrow, many cells. This is aplastic anemia. You see walls, etc., but you don't see people there. Hypocellularity. And no abnormalities, no fibrosis, no blasts, no excess malignant cells, no dysplasia, nothing like that. Well, post-hemorrhagic anemia, that is the one that is easiest to understand. Okay, we are bleeding, we are losing blood cells. Okay. Notice that healthy people can lose up to 20% of the blood volume, that means 1 liter of blood, without having any important clinical manifestation. That's why we can donate blood. When we donate blood, we donate like half a liter. Okay, so we are donating like 10% of our blood volume. Okay, and we can lose up to 1 liter without any important clinical manifestations. Of course, blood pressure is going to drop, we are going to feel thirsty, we are going to feel maybe weak, we are going to have some lightheadedness, etc. But it's not going to be anything important. Post-acute anemia, acute blood loss, is produced by a sudden blood loss in a person who has different levels of iron stores. People who have low iron stores also can bleed. And we are talking here about a patient that is bleeding and the rest of the things are normal. Now what happens in these cases, when you have a patient that is acutely bleeding, the less important thing that you are going to consider is the anemia. You have to stop the bleeding, you have to stabilize the patient, so the clinical manifestations of the anemia normally are going to be obscured by the cardiovascular manifestations like low blood pressure, tachycardia, cardiovascular shock, and all of the things that can happen when people is acutely losing blood. So in these cases, when people lose more than 40 to 50% of the blood volume, okay, even though we are worried about the blood pressure and the stopping the bleeding, etc., we have to know that this loss of blood will produce, besides the shock, will produce a lactic acidosis that will lead or make the person enter into a metabolic acidosis that is very hard to treat and person can die as a result of this acidosis. Okay, so one of the things that you have to do besides giving volume, besides giving blood if necessary, is pay a lot of attention to the arterial blood gases and to the pH of the blood, because we have to correct for these lactic acidosis. That's why we give Ringer lactate. Okay? Lactate sounds like lactic acid, but it's not lactic acid. It increases the production of bicarbonate and stabilizes and makes more alkaline the pH of the blood, preventing this lactic acidosis that occurs normally when people are bleeding too much. Well, more about hemolytic anemias. Hemolysis simply means a premature destruction of the red blood cells. Red blood cells can be broken for different reasons. Okay. They have an abnormal structure. They have a metabolic defect. We have antibodies that destroy them. Or there are mechanical defects in our body. For example, an artificial valve, okay, in the heart. You have something that is plastic or is metallic in contact with the blood. Of course, these cells are going to be broken. Imagine artificial valves smashing the red blood cells. In the cases of hemolytic anemia, normally erythropoiesis is intact. That's why you are going to have an increased reticulocyte count. Of course, remember, patients can have a combination of things. Someone can have a hemolytic anemia for one reason and anaplastic anemia for another, as a result of a treatment, as a result of a radiation, as a result of something else. Now, we are talking about a patient in which the bone marrow is normal, so we are controlling for the rest of the variables here. When you have these patients, you're going to have this increased or elevated reticulocyte count. The blood smear is going to show cells with different shapes, which is called what? Different shapes in the cells? Different shapes in the cells? You're studying pulmonology, not hematology. Different shapes in the red blood cells? Poikilocytosis. And different sizes? And anisocytosis. Okay. In the bone marrow, we're going to see erythroid hyperplasia. Okay. This can be seen in different conditions in which there is an increased erythropoietin stimulating the bone marrow. So it's not very useful. We are not going to need a bone marrow biopsy in order to make a diagnosis of hemolytic anemia. Bone marrow biopsy is a very painful and aggressive procedure, so we are going to try to use less expensive, less aggressive procedures. To diagnose hemolysis, we're going to do serum tests, which we are going to look for bilirubin. Normally the indirect bilirubin is going to be elevated. LDH is going to be elevated. And there is a protein that is called haptoglobin. That is very important in the diagnosis of hemolysis, because this protein is going to be low. If there is hemolysis and there is a lot of free hemoglobin circulating, haptoglobin is going to bind to this free hemoglobin, so the level of the free haptoglobin is going to decrease. So putting everything together, the bilirubin, the LDH, and the haptoglobin, plus of course the signs and symptoms, and the elevated reticulocyte count, we can say we are in the presence of a hemolytic anemia. This is the way we interpret the blood tests. There you have something that is just for you to see. It's not for memorization, of course, to see the different shapes that these cells can have. This is a normal red blood cell. This is a macroovalocyte. This is a microcyte, pencil cell, teardrop, target cell, Howell-Jolly body, reticulocyte, spherocyte, elliptocyte, stomatocyte, sickle cell, fragments, blister cells per cell. That is how many things can happen in the blood. Well, this is explaining why jaundice appears. Okay, here we have a red blood cell that is being phagocytosed by a macrophage. Can be in the liver, for example, because the cell is old or because the cell has any abnormality. Okay, inside the macrophage, all of the components of hemoglobin are going to be separate. Iron is going to be stored in the macrophage. Okay, this is the heme group. Iron is going to be stored. The globin parts are going to be broken into the amino acids. And this heme, this porphyrin ring here, okay, is going to be transformed into different compounds. The last of them is bilirubin. Bilirubin, notice that it's going to travel from the macrophage in the spleen via the portal vein, bound to albumin, to the liver. The liver cells are going to take this bilirubin and are going to bind to something that is called glucuronic acid. This binding of bilirubin to glucuronic acid is called conjugation. Okay, so now it's going to produce something that is called conjugated bilirubin. That is the one that is going to enter to form part of the bile. And in the bile, we are going to excrete it. So there are two types of bilirubin that we have to pay attention to. One is the unconjugated. It's the one that is here in the blood, bound to albumin, indirect or unconjugated bilirubin. And there is a conjugated bilirubin, the one that is processed by the liver. Remember that physiologic jaundice occurs because the liver is not mature enough to conjugate all of the bilirubin in the newborn. So these children are going to have certain degree of physiologic jaundice until the liver matures and is able to take care of this excess bilirubin. Now, these hemolytic anemias are going to be characterized by increased levels of this indirect or unconjugated bilirubin. The liver is conjugating, but can't work fast enough to conjugate all of the bilirubin that is in the circulation as a result of this hemolysis. So here you have the explanation. Globin undergoes proteolytic degradation in the macrophages, broken down to its amino acids. The heme group is catabolized to biliverdin, carbon monoxide, and free iron. Iron is stored. The biliverdin is reduced to bilirubin and exits the macrophage bind to albumin in the plasma. And this albumin-bilirubin complex is taken up by the liver and is conjugated to glucuronide, making it soluble in water. Okay? This unconjugated bilirubin has to travel bound to albumin because it's hydrophobic. When it enters the liver separates bilirubin from albumin and binds it to glucuronic acid, making it water soluble to form part of the bile. Now this conjugated bilirubin goes to the bile, goes to the duodenum, goes to the small intestine and to the large intestine. Okay, mixed with all of the contents of the intestine. In the gut, the bacteria convert the conjugated bilirubin to urobilinogen. This can go to the blood, this can go to the kidneys and be eliminated in the urine, giving color to the urine, urobilinogen, look at the name. And the rest, the one that doesn't go to the blood, the one that remains in the colon, will be converted to stercobilin, which produces the stool to be brown. Okay? These are the pigments that give the color to the urine, give the color to the feces. Now, in hemolytic anemia, the excess breakdown of the cells and the excess catabolism, breakdown of heme groups, will increase the amount of indirect or non-conjugated bilirubin in the plasma. And these people develop jaundice. Okay? If people have the, chronic hemolysis, they are going to develop, remember, bilirubin gallstones. Normal gallstones are cholesterol made. People with this condition have bilirubin gallstones. And here we have some conditions. Okay, one of them is hereditary spherocytosis. This is a condition in which the red blood cells have a membrane cell defect that instead of being a biconcave disc are round, completely round, abnormal shape. Enzyme deficiencies like glucose 6-phosphate dehydrogenase that we mentioned before, and sickle cell anemia and the thalassemias are also examples of diseases that can produce hemolysis as a result of these problems in the hemoglobin. There we have examples of diseases or conditions that can produce hemolysis. For example, autoimmune conditions like lupus, rheumatoid arthritis, non-Hodgkin lymphoma, something that we are going to study tomorrow, that is chronic lymphocytic leukemia. Some drugs, cephalosporins, dapsone, levodopa, levofloxacin, methyldopa, nitrofurantoin, NSAIDs, penicillin, quinine. Some infections like malaria, okay, Babesia, Bartonella, Clostridium perfringens, and traumatisms, people who have any kind of microangiopathic hemolysis, for example, disseminated intravascular coagulation, TTP, we're going to study this probably next week, thrombotic thrombocytopenic purpura, hemolytic uremic syndrome, people with malignant hypertension because of the very important vasoconstriction or generalized vasoconstriction, women with eclampsia. Okay, eclampsia is a complication of the pregnancy that you're going to study in OBGYN. Okay, people present with hypertension, edema, proteinuria, and in this case can have seizures and very important complications. HELLP syndrome is a syndrome that is characterized by hemolysis, elevated liver enzymes, and low platelet count that can appear in pregnancy. People with mechanical heart valves, hyperesplenism, liver disease, all of these conditions can produce hemolysis. Hemolysis, remember, can be intra or extravascular. In the case of the intravascular, there is an abnormality in the blood cell that makes the defenses of the body to recognize it as something abnormal. They can have antibodies bound to the cell membrane. These antibodies will attract the complement. So there is a complement-mediated lysis or direct cell trauma if they have a prosthetic valve, for example, or disseminated intravascular coagulation. This is hemolysis that is occurring within the blood vessels. People is going to have traumatic disruption of the red cell, producing red cell fragments. Okay? You are breaking down the red cells, forming what is called schistocytes. Okay? So it's very important that you know this concept. And a schistocyte is a red cell fragment that normally appears when there is intravascular hemolysis. Okay? Also, there will be release of LDH and hemoglobin into the circulation that will produce hemoglobinuria and decreased haptoglobin, because remember, this free hemoglobin is going to bind to haptoglobin. This is the way that we have to determine if someone has intravascular hemolysis. Okay, we find schistocytes, and we find a decreased level of haptoglobin. Now, if the hemolysis is extravascular, that means in the spleen, there is accelerated red cell destruction by cells in the reticuloendothelial system, spleen, liver, because of immune targeting of the antibodies. Sections of the red cell membrane are removed. It's like, imagine the red blood cells are traveling in the spleen. They have some antibodies bound to it, and the macrophages bite the cell, trying to phagocytose the cell. They take a piece of the red blood cell. Now, the cell membrane that remains is smaller, so they are going to become smaller red blood cells, looking like a sphere, and these are called spherocytes. Okay, they were bitten, and now they have a smaller cell membrane, and they become round. Appear as spherocytes on the peripheral smear. Now, if you test the amount of haptoglobin, it's going to be normal, because this is happening inside the spleen. There is no free hemoglobin going to the circulation, so haptoglobin will be normal, except if we have an exaggerated extravascular hemolysis and you have a lot of free hemoglobin going to the circulation and low haptoglobin. Okay? These are extreme cases. Haptoglobin tends to be normal when there is extravascular hemolysis. Well, clinical manifestations, these people have anemia. You know all of the signs and symptoms of anemia. And some people can have active infection. And some people can have episodic dark urine. Dark urine can mean many things, but one of the things that can mean is hemoglobinuria. Okay, if people have hemoglobinuria, their urine will be dark. These episodes were called, in the past, paroxysmal nocturnal hemoglobinuria. For some reason, we used to think that there was more hemolysis during the night. So the first urine in the morning was very dark, and then the urine could be normal during the day. But now we know that the hemolysis is occurring during the whole day at the same rate. Now we see it darker in the first urine in the morning because we have been accumulating more hemoglobin in the urine during the hours that we are sleeping. Okay, so the urine is very dark in the morning, it's getting more clear and more clear during the day to be completely clear during the night. But it's called episodic dark urine, and not so frequently paroxysmal nocturnal hemoglobin. You have here a link for you to study. Okay, this is paroxysmal nocturnal hemoglobinuria, but remember we are changing the name because we realize that this occurs at any moment. Okay, you have to look at these are samples of the urine of the same patient. Okay, notice how the color of the urine in the early morning is cola colored. Okay, this may occur at different times of the day and varies from patient to patient. Okay, episodic nature of the dark urine. So it's very good to read these things because these are details that help a lot to make our differentials. And here we have sickle cell anemia. Okay, which is a group of disorders. Okay, it's not a single disease. It's inherited in an autosomal recessive form. Some people are carriers, some people have the disease, so some people have what is called the sickle cell trait, and some people have sickle cell anemia, the disease. Sickle cell trait is something that protects against malaria, like thalassemia, like glucose 6-phosphate dehydrogenase deficiency. These people have a production of an abnormal type of hemoglobin that is called hemoglobin S. Or some people can have what is called hemoglobin C. It's less frequent than hemoglobin S. And this occurs because of a point mutation, genetic mutation in which there is a substitution of one amino acid by other. Valine replaces glutamic acid, and the shape of the hemoglobin changes under certain conditions. Okay, when the hemoglobin is well oxygenated, it is okay, like a healthy hemoglobin, but when it goes to deoxygenated form, deoxyhemoglobin, it stretches, elongates, instead of being globular, becomes like a stick and changes the shape of the erythrocyte. Hemoglobin S reacts to deoxygenation and dehydration by solidifying and stretching. Okay, the erythrocytes become elongated, sickle-shaped, and can undergo hemolysis, and also produce thrombosis and vaso-occlusive problems, pain crisis, and many things that can happen to people with sickle cell disease. Sickle cell trait is like heterozygous. They inherit the hemoglobin S from one parent and the normal hemoglobin A from the other parent. In the case of sickle cell anemia, they inherit hemoglobin S from the two parents. So most of the hemoglobin in the body is hemoglobin S, and the remainder is called hemoglobin F, that is fetal hemoglobin. Okay? One of the things that we can do with these patients is trying to stimulate the formation of hemoglobin F, or fetal hemoglobin, which will help them to have less crisis and less severe crisis. And for that, there is a medication that you're going to study in pharmacology. I think I put something about this here. This is just for you to see the distribution of the hemoglobin at birth. Hemoglobin F, fetal, accounts for 80% of the total hemoglobin. Okay, the other 20% is hemoglobin A. When we are 6 months of age, notice what happens. Healthy infants will have transition to hemoglobin A, and we will have a small amount of hemoglobin A2 and very little hemoglobin F. Okay, remember that 6 to 9 months of age is when the problems, for example, with thalassemias start presenting because of the decline in hemoglobin F. In the case of thalassemia, the hemoglobin A is going to manifest depending on the mutation that they have, the number of genes, etc. This shows the substitution, okay, of the amino acids. There is an amino acid replacement in the DNA, in the protein, because of mutations in the DNA, and will lead to the formation of hemoglobin S. This is the normal hemoglobin, and these are the fibers that are formed in the hemoglobin S when there is deoxygenation. That is the change in the shape of the erythrocyte, okay, that can produce occlusion in the circulation, in small blood vessels. So this patient presents with what is called vaso-occlusive crisis that can produce thrombosis, ischemias in different organs. Very painful crisis. Okay, abnormal hemoglobin S. Hypoxemia, low temperature, low pH, and decreased plasma, dehydration, will produce the sickling of the blood vessel, of the cells, and the clogging of the blood vessels. Okay? These sickle cells will produce hypoxemia. More hypoxemia will increase the sickling of the cells. It's like a vicious cycle. Okay? This decreased blood pH decreases hemoglobin affinity for oxygen. Oxygen pressure drops, increases even more the sickling. In the case of there is a reversal of the hypoxemia, so we rehydrate the patient, we give oxygen to the patient, and we increase the pressure of oxygen in the circulation, the sickle erythrocytes regain normal shape and resume the normal function. So these patients have to avoid any condition that leads them to low oxygen levels, for example, smoking, dehydration, infections of any type, okay, because any condition that produces acidosis, hypoxemia, etc., will create or trigger a crisis. Okay, you have a picture, real picture of these erythrocytes. Notice the shape, very elongated. Imagine these circulating in the capillaries. They are going to get stuck everywhere. They are going to attach one to another. They are going to create thrombi everywhere. So the most important determinant for this process is deoxygenation, besides all of the ones we mentioned before. Notice that the sickle cells in the persons with sickle cell trait will start sickling when there are tensions of oxygen of 15 millimeters of mercury. But those who have the sickle cell anemia, the disease, the cells are going to start sickling at 40 millimeters of mercury, the tension of oxygen. That's why people with sickle cell trait don't have too many of these crises or these obstructions in the circulation because they really need a very, very, very low pressure of oxygen in order to produce the cycling. And we normally, under normal conditions, we don't go to these low levels of oxygen. So these red blood cells are gonna plug in the blood vessels, are gonna increase the viscosity of the blood, causing vascular occlusion, painful crisis, organ infarction. So it depends on where the thrombus wants to appear, the damage that it's gonna produce. When there is viscosity, this increases the time of exposure to less oxygenated blood, to less velocity circulating, more time exposed to hypoxemia, more possibility of sickling. Now the sickle cells, because of their shape, will undergo hemolysis in the spleen or be sequestered there, causing a blood pooling and infarction of the spleen, of the splenic vessels. Anemia will develop, and this will trigger erythropoiesis in the marrow, and in the extreme cases, in the liver. So they are going to have extramedullary hematopoiesis, and will be the marrow of different organs producing cranial deformities, producing some skeletal deformities, fractures, splenomegaly, hepatomegaly, all of the things that appear when there is extramedullary hematopoiesis. So these are things that can appear. Okay? Anemia, very low levels of hemoglobin, hemolytic anemia. Splenic enlargement, fibrosis of the spleen, many infarctions in the spleen. Osteonecrosis and osteomyelitis. Remember, the bone marrow is growing, trying to compensate. Very thin cortex. Vasoocclusion of the blood vessels in the bones will lead to infections. Dactylitis, which is inflammation in the fingers, like sometimes look like sausages because of the inflammation. Ulcers because of the infarctions and necrosis in the legs. Many different painful crises. Strokes because of occlusion to the circulation in the brain. Okay. Chronic pain syndromes, chronic kidney disease, all of this thrombi, occlusion to the microcirculation in the kidneys. Priapism, one of the crises that can appear if there is occlusion, okay, in the veins of the penis. Cholelithiasis. They can have gallstones. Remember bilirubin gallstones producing cholelithiasis, cholecystitis, and many different manifestations. And these are triggers for this crisis that people with sickle cell anemia have. An infection, any travel to high altitude places or low oxygenation places. One of the things that produces a low oxygenation, remember, is smoking. That produces hypoxemia and increased carbon monoxide. Sarcoidosis. Okay. Some infections with herpes, diabetes, also dehydration, acidosis, extreme exercise, alcohol, pregnancy, and cold weather. All of this can trigger a crisis of sickle cell anemia. And here we have a medication that is used because it has many benefits for people with sickle cell anemia. That is called hydroxyurea. This is a medication that induces the production of fetal hemoglobin. Okay, lowers the amount of neutrophils and reticulocytes. This is very good because these neutrophils, if they are increased in number, they increase the coagulability of the blood and promote thrombus formation. So we are going to decrease the adhesiveness of the cells, red blood cells and neutrophils, to the endothelium, preventing the formation of thrombi. Hydroxyurea also reduces hemolysis and increases the release of nitric oxide, producing vasodilation and preventing this occlusion of the blood vessels. Okay, so many benefits by using hydroxyurea. And the last thing that we are going to see, I think, is the last thing. No, there isn't anymore. Where are we?
No, that's the.
Where's the last?
Yeah.
Where?
Yeah.
89.
Okay. I was sure there was elastic. Anemia of chronic inflammation. In this case, we have an anemia that is associated with any chronic infection. You have there AIDS, tuberculosis, rheumatoid arthritis, lupus, and cancers. So you have a patient that has a chronic severe disease. Okay, these conditions are going to cause a decreased erythrocyte lifespan. They are going to live a very short time. And failure of the compensatory mechanisms of erythropoiesis. Okay, there is a disturbance of the iron cycle. When we have an infection, when we have a chronic disease, when we have something that the body is very worried about, the liver is going to start producing a protein that is called hepcidin. Hepcidin is a protein that is released in response to infections, okay, in response to fever, in response to interleukin-1, in response to tumor necrosis factor. This hepcidin is going to increase the macrophage avidity for iron. Macrophages are going to take all the iron they can, bound to ferritin, and will reduce the intestinal absorption of iron. Okay? Now, what is that for? Simply, the body is trying to prevent the bacteria from taking this iron. Okay? Now, not only the bacteria will suffer, the bone marrow won't get the iron either. So it's not going to be able to produce more red blood cells. This is intended for the short term. We are supposed to have infections for a very short time, or either get better or die. Okay? Now, we have invented medications that keep us alive for many years with a chronic infection. So, the body hasn't been able to adapt. Okay, now it's not an acute infection, now it's a chronic infection. Let the bone marrow make red blood cells. The iron remains unavailable for bacteria and unavailable for the bone marrow. Manifestations are not as severe as other anemias. Okay, the signs and symptoms are very similar to iron deficiency anemia, but this is not a young woman with heavy menses. This is a person who has a chronic infection. So the signs and symptoms are going to be those of the disease and those of the anemia. Very important, this TIBC, when you do your blood tests, you are going to do for the total iron binding capacity. This TIBC measures the body's capacity to bind iron to transferrin. Remember, the protein that transports the iron from the macrophages to the bone marrow. In the case of iron deficiency anemia, the IBC is going to be high. There is a lot of capacity to bind iron to transferrin. The taxis, the transports are empty, waiting for iron. In anemia of chronic inflammation, the TIBC is going to be low. That is one of the most important diagnostic factors that we have, okay, to differentiate iron deficiency anemia from anemia of chronic inflammation. Low TIBC is going to be almost pathognomonic and specific of anemia of chronic disease. In the case of iron deficiency anemia, the TIBC is going to be elevated. In iron deficiency anemia, the liver makes more transferrin, is looking for iron to maximize the use of the little iron that is available. There is a lot of transferrin and little iron, so a lot of capacity, elevated capacity. In chronic disease, the liver makes less transferrin and more ferritin to keep the iron in the macrophages. So, little amount of transferrin, the iron that is available will be there, and there is no capacity. So, low TIBC, low TIBC. Okay, so, and who regulates this? Hepcidin. Hepcidin, remember, is produced in response to infection, to inflammation, to reduce the absorption of iron from the intestine, reduce the amount of transferrin, and increase the amount of ferritin. And this is for you to study at home. This is a very good flow chart. You are going to use to study anemia in your patients. Okay, you have what? You have a patient with anemia. Okay, you have a patient with anemia. In the CBC, you have your patient, you make a blood test, you detect there is low hemoglobin, low red blood cell count, low hematocrit, and you're going to evaluate the mean corpuscular volume, okay, to see if the cells are normal in size, are small, or are big. Okay, so you classify the anemia in macrocytic, normocytic, or microcytic. You have here the microcytic anemias. You have here a normal MCV, and you have here an elevated or large MCV, macrocytic. If you have a microcytic anemia, you have a spectrum of conditions that produce microcytic anemia. Then you study iron. Let me see if this is iron problem. Iron can be low with high TIBC, iron deficiency, high TIBC. Iron is low with low TIBC, anemia of chronic disease. Of course, don't stop here. If someone has iron deficiency, look for the cause. Where is bleeding? Or where is the problem? Is the diet? Is the bleeding? Is something? The same with chronic disease. Look for the disease. Look for the tumor. Look for the infection. Normal to high iron. Any TIBC, normal to high ferritin, you have to look for sideroblastic anemia, thalassemia. Okay? Depending on different studies, genetic studies, electrophoresis, the proteins, biopsies, different things. Blood smear is going to give you different things. Now, normal or normocytic anemia, well, you have to look for many things. Okay, for example, look for the blood smear, abnormal red blood cells, look for hemolysis, look for blood loss, look for bone marrow suppression, renal insufficiency, different causes of normocytic, normochromic anemia. And in the case of macrocytic anemia, you are going to look for B12 deficiency. Okay, you are going to look for folate deficiency. You are going to look for different causes of macrocytosis that appear there, the ones that we studied plus others that you're going to study in medicine and in the future. And also you're going to look for myelodysplastic disorders, okay, that we are going to study in the future, that they are precursors of certain leukemias. This is a very good chart that shows you different tests that you can use in your differential. More for medicine than for pathophysiology, but of course in pathophysiology we are going to be using certain of these findings, like MCV. Okay, this is very important in order to make a differential diagnosis in the TIBC to distinguish between chronic inflammation and iron deficiency anemia. Okay, and I hope this helps. Okay. Okay, see you tomorrow at the same time.
Thank you.
No problem.